So let's talk a little bit about thyroid. Does anybody know what this condition's called right here? What? Huh? Graves' disease. No, what this specific presentation is with the eyes. Called freaky eye syndrome. I'm just kidding. It's called exophthalmos, and it's going to be associated with immunoglobulins that start attacking the cells, that starts creating this condition where you have like bulging of the eyes, right? All the tissues that are in the back posterior portion of the orbit starts pushing the eyes out. And it's all going to be immunologically mediated. And yes, it's going to be associated with Graves' disease. Cool. So let's talk about the thyroid gland in more detail. So there's going to be two lobes of the thyroid gland, and they're going to be connected by the isthmus, right? So the isthmus is going to be this region right here in the middle. And then when you in the future are going to be working with your patients, when you do a physical exam, this is going to be part of your physical exam. You're going to be palpating for their thyroid gland. The best way to do that is by going from behind the patient. Otherwise, if you walk up to the patient with your hands like this, going towards their neck, they're probably not going to feel too great about that. So you want to have the patient seated, get behind them, and then you kind of palpate. You're going to look for the thyroid cartilage. And the thyroid cartilage is going to be the Adam's apple, right? And then you go a little bit below the Adam's apple, and then that's when you're going to be able to try to palpate for the thyroid. If you do feel the thyroid, then you're probably thinking the patient might have like a goiter, or the patient might have other types of like nodes that might be indicative of like thyroid cancers. Okay, so that's what you're basically looking for. So you palpate the lateral sides, so you can get the two different lobes. You can try to feel for the isthmus as well. You really shouldn't be feeling it too much on a physical exam. You're only really going to feel a thyroid if there's going to be some sort of like underlying condition affecting the patient's thyroid gland. In terms of cell types, there's going to be a couple different cell types. There's going to be the follicle cells, right? And then you also have the parafollicular C cells. Now, in terms of what these different cell types do, the follicular cells, the follicle cells, are going to be associated with the actual production of T3 and T4. Whereas the parafollicular cells are going to be predominantly associated with the production of calcitonin. Okay, so there's going to be two major hormones, well, three major hormones produced by the thyroid gland, T3, T4, and then calcitonin. T4 is going to be the one that's mostly produced, T3 slightly produced, but T3, if you guys remember from last week, is going to be the type of thyroid hormone that's actually active. I'm going to show you a nice little breakdown chart where it shows the difference between T3 versus T4. It's kind of good to have a general idea of what either of those hormones are doing. Let's see. And then in terms of the actual cell types, you're going to have cuboidal cells that surround the follicle cavities. And cuboidal cells are usually going to be associated with like secretion. And so that's where you're going to actually see the secretion of thyroid hormone. And then inside those cuboidal cells, inside the follicle cavity, you're going to see like a viscous type of like fluid type material that's going to be inside there. And it's going to be like a colloid. That's where you see all like the proteins kind of hanging out in solution. And then you're also going to have a lot of capillaries, right? Because a lot of these endocrine type tissues are going to be highly vascularized because you have to secrete hormones directly into the bloodstream. Does that make sense? And then let's see. Let me show you a little video about the thyroid gland here. A very short one.
Thyroid examination. Examination of the thyroid gland starts with inspection. In doing so, it's important to consider the gland's anatomy and its surrounding structures. The thyroid cartilage is a helpful landmark. The thyroid can be palpated bilaterally below. In healthy individuals, the thyroid only weighs around 18 to 25 grams and should not be visible. An enlarged thyroid, otherwise known as goiter, is considered class 2 if macroscopically visible. When the head is reclined, thyroid enlargement can be seen even earlier. Palpation is usually performed from behind, although anterior palpation is also feasible. The gland is often only detectable upon palpation if a pathology is present, such as nodules, enlargement, or an altered consistency. You should also note any tenderness to touch, as seen in inflammatory changes, such as a viral infection. To assess the mobility of the thyroid gland, ask the patient to swallow and offer a glass of water if necessary. If thyroid perfusion is increased, like in Graves' disease, examination may reveal an auscultable bruit and a palpable thrill.
Cool. So that sound of a bruit would be kind of like a low rumbling type of sound. That's going to be due to the hypervascularized nature of a hyperactive thyroid gland. All right. Cool. All right, so here's another image summarizing those different regions. So you're going to have those two important cell groups. You have those follicle cells, which actually are going to be implicated in the secretion of T3 and T4, and then you have your C cells, also known as your parafollicular cells. They're going to be associated with the release of calcitonin, which we're going to describe a little bit later. So here's that thyroid cartilage I was talking about. If you go a little bit below the thyroid cartilage, it's about like a 2 fingers breadth distance below the thyroid cartilage, is where you're going to actually be able to find the thyroid gland, most notable on the lateral sides, and then you do have that connection across for the isthmus. Cool, so let's talk about how thyroid hormone is produced and stimulated. So when your thyroid hormone is low, so you have low T3, low T4, then you're going to have a positive feedback loop stimulating the hypothalamus to go ahead and begin releasing thyroid-releasing hormones. So that's going to be your TRH. Because remember, in your hypothalamus, that's where you have releasing hormones and inhibitory hormones. Then once TRH is released from the hypothalamus, then it's going to stimulate the anterior pituitary to begin producing and secreting thyroid-stimulating hormones, so TSH, okay? And then TSH is going to eventually stimulate the thyroid gland to start doing its thing, to start producing T3, T4. And then the opposite is going to be true. So if you have T3 and T4 in really, really high amounts, then it's going to cause a negative feedback loop, and that negative feedback loop is going to inhibit both the pituitary gland, specifically the anterior pituitary gland, and it's also going to inhibit the hypothalamus. So it's going to signal to the hypothalamus to stop secreting TRH. And then in terms of the receptor types, they have to have specific receptors for those specific hormones, whether it's the releasing hormone, stimulating hormone, etc. Right? Because if you recall from last week, all of these are going to operate in a lock and key type fashion. Now let's talk a little bit about the two different cell types. So you have those follicular cells, and follicular cells are what are implicated in T3 and T4. And then also when they produce T3 and T4, there's going to be thyroglobulin. Now remember the difference between bounded hormones versus free hormones. Which ones last longer? Bounded. Bounded hormones are going to last a lot longer than free hormones. Free hormones tend to get degraded within about a day. Each hormone has its separate half-life, but after about a day or so, it's going to be metabolized by the liver or the kidneys. And then thyroid globulin is going to be the actual protein carrier that binds to those hormones, creating a bounded hormone complex. And then, as I mentioned before, and we're going to talk about this again, thyroxine or T4 is going to be the most abundant. It's going to have 4 different iodine molecules associated with it. So you have a little image right here that I included. So you got thyroxine. It's got 4 different iodines. And then you have the triiodothyronine, which has only 3. And there's also a diiodothyronine, which is going to have 2 iodines. So the way that those follicle cells actually produce the thyroid molecules, thyroid hormones, like for instance, T4 is often going to be synthesized by combining 2 diiodothyronines. So you have a final product of a thyroxine with 4 iodines. And then on the other hand, you have your parafollicular cells, right? AKA the C cells. And those are going to be associated with calcitonin. And we're going to go through all the different pathways of how calcitonin is going to be stimulated. And then here's just another summary of how the positive and negative feedback loops are going to be activated depending whether or not the patient has too much thyroid hormone or versus too little thyroid hormone. So here's another summary of all that, right? So you have all these different steps here. Moving forward. All right. So let's go over that positive feedback loop. So if you have your homeostasis, right? Homeostasis, maintaining the balance of your different physiological components. If you have too little T3 and too little T4, then your body's going to try to maintain homeostasis. Okay, and then you're going to stimulate the hypothalamus to release TRH. The hypothalamus is going to release TRH down towards the adenohypophysis, aka the anterior pituitary. And then once you get that released, releasing TSH, then you're going to have thyroid hormone being released by the thyroid gland. Cool. So let's talk about what the thyroid hormones actually do and certain conditions by which you'll see some disorders with thyroid hormone, i.e. hypothyroidism versus hyperthyroidism. Okay, so T3, T4, those are going to be the major hormones. T3 is going to be the major one that's actually effective throughout the entire body. T4 is going to be mostly inactive. They're going to be binding to different types of receptors. So you can find binding of thyroid hormones to not only the cytoplasm, like components inside the cytoplasm, you could see them binding onto mitochondria. If you remember from last week, once they stimulate mitochondria, then the mitochondria is going to start producing more and more ATP, right? So that's why if you have a patient with hyperthyroidism, that's why they're going to be extremely energetic to the point where it gives them even anxiety, right? Because they're going to be energetic. They're going to start being like overheated because they're being overworked. In other words, their basic metabolic rate is going to go really high, like super through the roof. And then you also have binding to the nucleus. And when it binds to the nucleus, it's going to affect sodium-potassium pumps. Some people are going to be born with low thyroid levels. And if you do get low thyroid levels, congenital hypothyroidism is going to be referred to as cretinism. Okay? Cretinism is going to result in this type of you have short stature. You might actually have some like cognitive disability. There's going to be a lot of different things that are going to happen downstream of congenital hypothyroidism. One of the main ways that we were able to fight congenital hypothyroidism was through iodine supplementation, right? AKA fortifying salt. That's one of the major ways that we were able to combat hypothyroidism. Back in like the 18th or 19th century here in the U.S., we had a really high amount of cretinism because there was a lot of people that were eating diets that were very poor in iodine. So that's when we all discovered that we need to start supplementing with iodine. These regions over here, like sub-Saharan Africa, places like that where they maybe have not really great infrastructure, or maybe they don't really have great access to healthcare, that's when you see in those regions an increased rate in cretinism. Yes. Hyperthyroidism? Yes, definitely. If your basic metabolic rate is elevated, then your body is like producing lots of energy, which means that yes, you're going to definitely lose a lot of weight. So people who are hyperthyroid tend to be a little bit skinnier versus people who are hypothyroid, because of their reduced basic metabolic rate, they're going to tend to gain weight a little bit more readily than they would otherwise. Cool. So this is a chart that talks about the differences between T3 versus T4. So with T3 versus T4, T4 is going to be the one that's mainly produced, right? You're going to get much more T4 produced than you would T3. It's like anywhere between 80 to 90%, depending on what textbook you're looking at. Versus T3, that's going to be the one that's actually active, and it's going to be active throughout the entire body. There's going to be a lot of different functions that T3 is going to be involved in. T3 is going to be triiodothyronine versus T4 is thyroxine. If you guys know anybody that's hypothyroid, they're probably taking thyroxine. T4 is going to be like the basic medication that patients with hypothyroidism are going to be prescribed. And it's also kind of like challenging too, because you want to be very careful. You don't want to take too much thyroxine, so you have to like monitor the dose, because if you take too much, you can throw your hormones in like huge imbalance and disarray. One of the most common and most disconcerting symptoms for thyroid imbalance is going to be hair loss. So a lot of people don't want to lose their hair, right? So you want to make sure that your thyroid hormone is going to be in proper balance. In terms of potency, T3 is going to be much more potent than T4 in terms of its physiological effects. And then T3 is going to have a much shorter half-life than T4. Those are going to be some of the major key differences between T3 and T4. Actually, let me go back real quick here. A little video I want to show you.
Hormone is produced in T3, which is the active form of thyroid hormone, and T4, which is an inactive precursor to T3. Most of the thyroid hormone that's produced by the thyroid, about 80%, is present as T4, only 20% is secreted as T3. T4 travels to the target tissue through the bloodstream where it's converted to active T3. Thyroid hormone requires iodine for its production, as iodine is a key structural component of the thyroid hormone. T3 consists of 3 iodine, whereas T4 consists of 4 iodine. Thyroid hormone synthesis occurs at the follicular cell and colloid in the follicles of the thyroid. This involves several steps, which we'll review in the next few slides. The first step of thyroid hormone synthesis is iodine uptake. Iodine from the bloodstream is transported into the cells via a sodium iodine symporter. The iodine is then transported into the colloid. In the colloid, an enzyme called thyroid peroxidase, or TPO, oxidizes the iodine and then catalyzes its binding to a protein called thyroglobulin. Upon binding to thyroglobulin, the iodine forms thyroid hormone precursors, DIT and MIT. These precursors are coupled together to form T4 and T3. T3 and T4 are then taken up by the cell, dissociated from the thyroglobulin molecule, and secreted into the bloodstream, where they travel to the target tissue.
So I hope you like this video. Absolutely make sure to check out the course.
Go away. And by the way, I misspoke earlier when I said diiodothyronine. It's actually diiodotyrosine. Okay, so those are going to be some of the precursors for T3 and T4. So if you look at T4 over here, it's going to be made up of 2 of those diiodotyrosines combined together. So now you have 4 iodines. And then MIT is going to be monoiodotyrosine. I apologize for that. So here are some of the effects that thyroid does on the body. So the thyroid is going to be implicated very heavily in calorogenic effects. So in other words, when you hear the word calorogenic, calories, calor, si tu hablas español, or even like Latin, it's going to be very similar. Calor just means heat, right? So these are going to be involved in like heat production. That's why if a patient is hyperthyroid, they're going to be very heat sensitive. They're going to be really intolerant to hot temperatures. They might even sit in this room and think that it feels excessively hot in here. Versus the opposite, right? If they're going to be hypothyroid, they're going to be very sensitive to cooler temperatures, very temperature intolerant. And that's all associated with metabolism, right? That's going to be your metabolic rate or basic metabolic rate. And then here are other things that the thyroid hormone are going to be implicated in. So you can see that it's going to affect oxygen consumption as well as energy consumption. So more thyroid, more energy consumption, more oxygen consumption because of aerobic respiration. You're going to actually see elevation in heart rate. So a little bit of a tachycardia with these types of patients if it's hyperthyroid, because it's going to be involved in like cranking up your metabolic activity. Also think about your sympathetic nervous system. Sympathetic is going to be your fight and flight, right? So you're going to have an excessive amount of sympathetic activation. You're also going to see a little bit of erythropoiesis. So you're going to see some red blood cell formation and stimulation just because you're going to have a greater demand for oxygen, which is going to thereby increase your requirement to produce red blood cells so you can meet that demand. And interestingly enough, you're also going to see a turnover of minerals in bones. So let's talk about calcitonin, speaking of bones. Calcitonin is going to be the other major hormone that's produced by thyroid gland, right? So calcitonin coming from your C cells, aka parafollicular cells. If a woman has menopause, right? Once a woman undergoes menopause, then they're no longer able to produce their sex hormones. One of those sex hormones that's going to be associated with bone maintenance and development is going to be oestrogen. Okay, so if a person if they undergo menopause, they no longer can produce estrogen, then they're also going to get, secondary to that, osteoporosis. Okay, so they're not able to fully form their bones, and so you're going to see a greater degree of like bone fractures and things like that in those types of patients. To be able to combat this, to be able to treat this, you can actually give the patient exogenous calcitonin. And if you give them calcitonin, what does calcitonin do? It increases the tone of like the calcium. In other words, it increases bone building, bone reabsorption, building up the bones, so you reduce the calcium levels in your bloodstream. And if you increase the bone density, then you're going to have a reduction in things like fractures, etc. So parafollicular cells, that's where you see the production of calcitonin. The ultimate goal of calcitonin is to drop the overall levels of calcium in your bloodstream. If you have too much calcium in your bloodstream, you're going to see all sorts of different effects. If you have too little calcium in your bloodstream, you also see a lot of different effects from that. So you want to try to maintain that homeostasis by maintaining a good level of calcium. The way that calcitonin works in doing that is that it's going to actually inhibit osteoclasts, right? And it's going to stimulate osteoblasts. Now, if osteoblasts are what help to build up bone, osteoclasts are what help to, I guess for the lack of better words, crush bone down. So think clast, breaking down calcium. So it's going to be involved in calcium resorption. And then building up bone is going to be your osteoblasts. All right. And calcitonin is going to help to stimulate and inhibit those different cell types in your bones. So here's another image of what that would look like in terms of calcium levels. So if you had way too much calcium, the patient is hypercalcemic. It's going to affect the thyroid gland and stimulate the release of calcitonin. Once calcitonin gets released, then you're going to have, hypercalcemia. You're going to want to build bone, right? So you're going to take all that free calcium out of the bloodstream and you're going to put it somewhere. And what's the best place to put it? It's going to be in your bones. Okay, so it's going to stimulate osteoblasts and it's going to inhibit osteoclasts. And then overall, the net effect is going to be a total reduction in calcium levels in your bloodstream. Okay. Let's see here. And now let's talk about other diseases of the thyroid gland. A lot of these diseases are going to be subcategorized in 3 different categories. So primary, secondary, versus tertiary. If it's primary, it's going to be at the actual level of the thyroid gland itself. Okay? Secondary is going to be at the level of the pituitary gland, and then tertiary is going to be at the level of the hypothalamus. Okay? So, for instance, if you had secondary hyperthyroidism, what would be causing the actual hyperthyroidism? What hormone specifically? TSH. Awesome. Good. So thyroid stimulating hormone would be associated with secondary hyperthyroidism. Maybe you have a pituitary adenoma. So that pituitary adenoma is causing an excessive release of thyroid stimulating hormone, which is going to thereby cause an excessive production of thyroid hormone. And then primary hyperthyroidism, maybe you have like a toxic nodule that's secreting way too much thyroid hormone. That would be associated with primary hyperthyroidism. And you can also have the opposite for hypothyroid. If you had primary hypothyroidism, then your thyroid gland is not producing enough T3, T4. Secondary hypothyroidism would be associated with the pituitary, and tertiary hypothyroidism associated with the hypothalamus. So here's another image of that, just, trying to nail this home here. So you have your thyroid hormones. If it's low, it's going to cause a positive feedback loop. If it's too high, then you get a negative feedback loop. And depending on what kind of condition the person might have, you might see these feedback loops not functioning properly, right? That's kind of like the foundation of a lot of those conditions. And we're going to talk about some of those in greater detail over here. So let's talk about hyperthyroidism. So a hyperactive thyroid gland. If you have primary hyperthyroidism, you're thinking that the patient might have, for instance, Graves' disease. That's just one example of a condition that results in hyperthyroidism. hypothyroidism. With hyperthyroid, you have way too much T3, T4 being produced. Then you have a negative feedback loop, right? Because you're producing way too much of those hormones. Your body is basically saying, like, stop, stop producing all those thyroid hormones. Let's try to turn off the pituitary as well as the hypothalamus. But despite the efforts of reducing TRH, thyroid releasing hormone, and reducing TSH, the gland is still producing an abnormal amount of thyroid hormone. Now the patient becomes hyperthyroid, and it's going to result in a couple different signs and symptoms, among other things, right? Like the temperature increase, temperature intolerance, increased basic metabolic rate. You're also going to see goiter formation, where you have enlargement of the thyroid gland, as well as exophthalmos, the bulging of the eyes. Then with secondary hyperthyroidism, that's associated with the pituitary gland. Maybe you're thinking the person has like a pituitary adenoma, okay? And if they do have a pituitary adenoma, you might see, you're going to see potentially an increase in TSH, because that's at the level of the pituitary. That TSH is also going to increase your T3, T4. But you're going to have a reduction in TRH. Your hypothalamus is trying its damnedest to try to reduce the amount of TSH being secreted. But to no avail, because the pituitary gland is basically doing its own thing. It's running amok. And then tertiary hyperthyroidism is going to be an increase in all of those hormones, because you have increased TRH, which is going to increase TSH, which thereby increases your thyroid hormones. You can actually see that under conditions of hypothalamic tumors. I included an article in there that's from the NIH, I believe, and they talk about different effects that hypothalamic tumors can result in, one of which is hyperthyroidism. So that would be considered tertiary hyperthyroidism. Oh yeah, and by the way, I included these images over here. These are like radiographic studies where you check to see the activation and the activity, like hyperactivity of the thyroid gland. Depending on what it is, you might have like a toxic nodule, and so you can see exactly where in the thyroid gland you're seeing the excessive amounts of thyroid hormone production. Also, they're using radioactive iodine isotopes, and that's what they're actually measuring in these images for like radiographic studies. So iodine is being taken up excessively by your thyroid gland, and that's going to light up on these types of radiographic studies. Normal iodine uptake is just going to look kind of nothing really too crazy. Graves' disease, you see the entire thyroid gland, all of it is having excessive amounts of uptake in that radioisotopes of iodine. And then those toxic nodules, those are going to be isolated to one specific region of the thyroid gland. Cool. So let's talk a little bit about Graves' disease. The underlying issue in Graves' disease is going to be autoimmune. So it's an autoimmune disease in nature. And so because of its autoimmune nature, it's going to involve antibodies. And those antibodies are going to thereby stimulate, very similar to the way TSH does, they're going to stimulate the production of T3 and T4. All right? And then just like other hyperthyroid conditions, you're going to see very similar signs and symptoms: increased body temperature, increased blood pressure, increased heart rate, increased metabolic rate. So you're basically seeing everything go up. Okay? And then other things that you're going to see in terms of symptoms are going to be exophthalmos. So exophthalmos is going to be also immunologically moderated. The immune system effectively is just attacking its own cells, and because of that immunological response, then you start seeing swelling of those tissues. You can reverse this once you start treating the underlying condition, right? If you can help to like minimize the amount of thyroid hormone being released, usually through surgery, or you could also do radioactive iodine, it's like a radioactive iodine ablation. So basically, you give the patient a bunch of radioactive iodine. The thyroid gland exclusively takes that up, and because of that, you get destruction of the thyroid gland altogether. If you do that, what's going to be the consequence of that? By the way, this is just a side note. If you wipe out the patient's thyroid gland, what's going to happen to the patient? Pretty straightforward. Nothing really too crazy. Huh? Yeah, you basically just induced hypothyroidism. And now they're going to be hypothyroid for the rest of their lives. So if you do a radioactive iodine ablation, that's going to wipe out their thyroid gland. And for the rest of their lives, they're going to have to exogenously supplement with thyroxine. They have to take exogenous thyroid hormone for the rest of their lives. Not the end of the world, but it's a lot better than having to deal with that, right? So here's some more information. By the way, this is all just FYI on this slide. This is a lot, but this is just kind of like an overview of all the different things going on in Graves' disease. So you're going to see hyperthyroidism. You do see women being more affected by Graves' disease. These are the age brackets in which you do see the onset of Graves' disease. And this is the major immunoglobulin that's going to be associated, right? So it's going to be thyroid-stimulating immunoglobulin. That's basically what's going awry, stimulating the thyroid gland excessively. And so then you see an excessive amount of T3, T4. You see exophthalmos. You see also pretibial myxedema. Myxedema is basically just like swelling of tissues. And for whatever reason, you see that happening as well on the tibia. So pretibial myxedema is one of those signs and symptoms of Graves' disease. I'm not going to test you guys on that. Once you guys take like pathology, pathophysiology, you will be tested on that. But I'm not going to test you guys on that. And then you can do these types of tests to be able to diagnose. So you can test blood markers, right? You can see how much thyroid hormone is being produced. If you see an excessive amount of T3, T4, but you see a reduction in the levels of TSH, then you know that you're dealing with the primary hyperthyroidism. Because the pituitary gland is like basically trying to reduce the amount of thyroid hormone being produced. Okay? And then this RAIU, that's radioactive iodine uptake. And so that's what you see in these little images over here. That's a radioactive iodine uptake test. And so you can actually see exactly how much iodine the gland is taking up. What's up? Hypothyroid, yeah. Yeah, you wouldn't want to take thyroxine if you had A, normal, if you're like, they call it euthyroid, that means you have normal level of thyroid hormone, or if you had too much thyroid, you would not want to take thyroxine. That'd be a really bad idea. You'd be probably in a lawsuit after that. Anyways, and then for hyperthyroid, you could do all these different tests, treatments. You can do different types of meds. So one med is propyl thyrouracil, and then you could do the radioactive iodine treatment. I actually had a friend who did this, the radioactive iodine treatment. He's got Graves' disease, but it keeps on coming back, even though he's doing the radioactive iodine treatment. So for whatever reason, the tumor just keeps coming back. Usually, when you do this, the radioactive iodine treatment, usually that just eliminates the problem altogether. It gives you another set of problems. You have to take exogenous thyroxine, but that's about it. Or you could just go surgical route. You could actually have a doctor go in there, perform the surgery. It's a very risky surgery because you have the recurrent laryngeal nerves right around there. And if you mess up, it's a very easy nerve to slit, to cut accidentally. And you can actually make the patient lose their voice permanently if you do it bilateral. If you have one side, they could still like recover a little bit. But if they do a bilateral severing of that recurrent laryngeal nerve, they basically become mute for the rest of their lives. So it's kind of a scary surgery. The radioactive iodine treatment is going to be one of the best ways to address Graves' disease. Cool. So let's talk about hypothyroidism. So that's going to be the opposite. And similar to hyperthyroidism, you're going to see women being more predominantly affected than men. And then the major disease is going to be this guy right here, Hashimoto's disease. That's going to be the major cause of hypothyroidism. And then the opposite of hyperthyroid, you get all the different symptoms, right? You see a decrease in your basic metabolic rate. You see a decrease in your body temperature. You see fatigue and weight gain, right? And then you can also see goiter formation too. You do see goiter formation with hyperthyroid, but you can also see goiter formation in hypothyroid as well. And I'm going to go through a little, it's like a little graph so we can try to predict whether or not a patient's going to get goiter. We're going to talk about that a little bit later. It's not yet in your guys' version of the lecture notes. I'll post those towards the end of the week so you guys can have access to that. But we'll go over all those as well. Now, in terms of hypothyroidism, one of the major reasons why you see that taking place, you could see it being with autoimmune disease. You could see the patient just naturally not having enough iodine in their diet, right? So if you don't have enough iodine in your diet, you're not going to be producing thyroid hormone whatsoever. Or, just like we talked about with a patient with hyperthyroidism, like Graves' disease, if they get their thyroid gland removed either surgically or through radioactive iodine treatment, then you're going to see hypothyroidism as a result. Radiation in general. One of the main, whenever there's a fear of like a nuclear attack or a nuclear meltdown of like a power plant or something, there are going to be certain types of meds you can take to help protect your thyroid gland. It's going to be a very high amount of iodine. So in other words, despite being exposed to radiation, because you have a lot of normal iodine, if you take these pills, iodine pills, then your thyroid is going to prefer to take up the normal iodine. So it's not going to give a chance for radioactive iodine to be taken up. But if you were exposed to radiation, whether it was, nuclear fallout or even under conditions of being in like a hospital setting, working in radiology, if you had like damage to your thyroid gland, radiation can also cause hypothyroidism. And there's different types of drugs that can affect the thyroid gland as well. I'm not going to test you on those, but lithium is an example of that, potassium iodide, etc. So the signs and symptoms of hypothyroidism, these are all the different signs and symptoms. As you see in this little illustration here, the person's wearing mittens, right? They're really, really cold. They're very temperature intolerant. You also see other parts of the body being affected as well. So remember I mentioned that you can see a lot of like alopecia being associated with thyroid imbalance, aka hair loss. You might see a receding hairline. You can also see like, dryness. So you can see the skin being affected as well. So you might see dry skin. You're going to see a greater degree of constipation in hypothyroidism. What would you see in hyperthyroidism? Do you think you'd see constipation as well? Huh? Diarrhea, yeah, because you're going to have overactivation of your body, including your GI tract. So you're going to have excessive activation of GI. You're going to have diarrhea as a result. Makes edema, and then also you might see a coma if you have a complete imbalance of a lot of your ions. So you might see an imbalance of sodium. You might see your body temperature dropping so low that it's actually going to result in a serious crisis, an emergency. So you might have a myxedema coma as a result. So that's going to be on the more extreme end of hypothyroidism. So let's go over primary versus secondary versus tertiary hypothyroidism. So with primary hypothyroidism at the level of the thyroid gland, you're mostly going to be seeing Hashimoto's disease as the primary cause of that. So in other words, it's at the level of the thyroid gland. So you're going to see a reduction in T3 and T4. Because of that, you're going to see an elevation in both TRH and TSH, because the hypothalamus and the pituitary are trying to overcompensate for the reduced amount of T3 and T4 in the body. You don't need to know these guys over here, but these are all the different immunoglobulins and antibodies that are associated with development of Hashimoto's. So anti-thyroglobulin, anti-thyroid peroxidase, etc. But I'm not going to test you on that. That's more like a pathophysiology type of question. Secondary hypothyroidism at the level of the pituitary gland, you see a reduction in T3, T4, but because it's at the level of the pituitary gland, you also see a reduction in the amount of TSH being produced. But you're going to see an increase in the amount of TRH, or thyroid releasing hormone, from the hypothalamus. And then with tertiary, it's basically global. You see a reduction in every single one of those different hormones, from the level of the hypothalamus all the way down to the thyroid gland. And these are going to be the major symptoms of Hashimoto's disease. You see like lethargy, you see the patient's cognition being affected, right? So they have brain fog. You will see goiter formation, constipation, fatigue. You do see changes in the patient's menstruation as well if they're within reproductive age. You might see effects on their skin. and then you might see joint pain as well. So let's watch a little video on hypothyroidism, Hashimoto's.
Have you noticed that your neck seems swollen lately? You could have a condition called Hashimoto's thyroiditis. The thyroid is a small butterfly-shaped gland in your neck that produces hormones, chemical messengers that regulate many organs and functions in your body. A thyroid imbalance can cause problems throughout your body. Hashimoto's thyroiditis is an autoimmune disorder which causes the immune system to attack the thyroid so it is unable to produce the hormones our body needs to function properly. This can eventually cause hypothyroidism and symptoms like these. Hashimoto's thyroiditis is the most common thyroid disease in the United States, affecting over 10 million people. It runs in families, and women are 7 times more likely to suffer from this disease. Hashimoto's thyroiditis progresses slowly over many years, and many people don't know they have it. If you just aren't feeling right or your neck is swollen, Hashimoto's thyroiditis could be the cause. There is hope and help. Your healthcare professional can determine if you have Hashimoto's thyroiditis or another type of thyroid disorder.
All right, you guys get the picture, right? All right. So remember I mentioned cretinism. This goes into more details about the different symptoms that you'll see in cretinism. Just know that in cretinism, that's congenital, right? Mom did not get enough iodine in her diet, probably because, she probably didn't have good access to, nutrition, food, or she was just living in one of those regions that don't have great access to healthcare, don't have really good infrastructure, don't even have things like fortified salt that's ionized. So these are all the different things. You can see like mental and cognitive impairment because of that. You might see poor ossification of bones. You might see short stature as well. And some of these different types of features as well. So you might see flat nose. You might see skin being affected. You might see kind of like swelling or puffiness of the face. So that's all, or that would be all the different signs and symptoms of cretinism. So not great. And then this is myxedema. So myxedema, just think of it as being like just excessive swelling of soft tissues. Oftentimes you're going to see it around the eyes. You're also going to see it, different regions of your neck maybe. So just kind of like an overall puffiness. And there's a dog here because guess what? Pets and animals, they can also get conditions like hypothyroidism, right? And by the way, it is reversible. So these images over here, if you do treat the underlying condition, you could potentially reverse those signs and symptoms of the disease. Cool. So let's kind of beat a dead horse at this, but let's just go through it one by one. With low T3, T4, what's that called? Hypothyroidism. What would you see in terms of weight changes? Weight gain. Oh, shoot, I probably should do both. So you see weight loss is going to be for T3, T4 if it's increased. So that's going to be hyperthyroidism. What about heart rate? Low and then high. Good. And then what about blood pressure? Low and then high, right? What about temperature? Okay, good. You guys are awesome. All right. What about temperature? Intolerance. Huh? Okay, I'm going to call on somebody. You. You. Yes. Are they going to be intolerant to cold or to heat? If it's low? Yeah, exactly. So I mean, temperature intolerance to cold if it's low, temperature intolerance to heat if it's high. Okay? A question like that might be on your test. I just decided. Mood. What's going on with mood? What's going to happen if they're low in thyroid hormone? They're going to be like depressed. They're going to be like lethargic. What about if their thyroid hormone is really high? Anxious, anxiety, like they're freaking out. They don't know what the hell's going on with them. They're going to be energetic. What about their bowels? Talked about this already. Constipation versus diarrhea. Awesome, good job. And then this is a summary of what hyper versus hypothyroidism looks like. So, dude with the fan over here, he can't tolerate how absolutely hot it is here in Arizona when it's 120 degrees outside in the summer. Who would have thunk? anyways, moving on. Goiter. So not all thyroid conditions are going to result in goiter, but if you do see goiter formation, it's going to be involving, you can get multiple different nodules. It's going to be associated with a lot of stimulation of the thyroid gland in general. So in other words, what kind of, we're going to go through a little chart on what type of hypothyroidism you might see goiter formation. So I included a link to the Mayo Clinic that talks about goiters. And then here's a couple images of more mild type goiters. Nothing really too crazy here. But you can also get really severe goiters as well, depending on the level of severity of the illness. So not great. And you can also get goiters surgically removed, as you see in this image over here. So let's see. Let's go through a couple examples. Oh, man. Okay, good. Let's go through the levels of hormones to try to figure out if it's primary versus tertiary versus secondary, etc. So if you have primary hyperthyroidism, what's going to be the levels of T3, T4? High? Up, right? What about TRH and TSH? Low? For both of them? Good. Yeah, so you're going to see reduction in TSH and TRH. What about secondary hyperthyroidism? What's your T3, T4 levels? Up? High? Oh, dang it. TSH is also going to be high because it's going to be secondary at the level of the pituitary. So that's going to result in high T3, T4. What about TRH? Low. Awesome. What about tertiary hypothyroidism, aka at the level of the hypothalamus? It's all going to be what? It's all going to be high? It's all going to be high because it's hyperthyroidism, right? The end result is going to be an elevation in thyroid hormone, T3, T4. And because it's at the level of the hypothalamus, everything is going to be elevated, right? TRH stimulates TSH, which thereby stimulates T3, T4. Let's talk about goiter formation a little bit here. So goiter formation is going to be basically associated with like excessive activation of the thyroid gland. It could also be an excessive amount of those thyroid stimulating globulins. Okay? So if it's an autoimmune type disorder that's involving thyroid stimulating globulin, that's like a pathogenic amount of like immunoglobulins basically stimulating the thyroid gland, you might see goiter, you might not see goiter. So let's find out. So primary hypothyroidism, what's T3, T4 levels? Huh? Low, good. What about TRH, TSH? High? Good, they're both going to be high. Do you think you're going to see a goiter in this? Who wants to take a guess? No or yes? Flip of the coin. Are you going to see it? You said no. Did you say no? You said no. Why would you think that you wouldn't see a goiter in that situation? Is really low? That's a good way to think about it, but that's actually incorrect. What's going on, because the because the T3 and T4 is so low, the pituitary gland is really trying hard, like the hardest it can, to try to stimulate the release of T3, T4. As a result, you're going to have way too much TSH, which is going to affect the thyroid gland as a target tissue, and you will see, I didn't put it in there. You will see on the bottom, when I get to it, you will see goiter formation under those conditions, okay? All right, and I just gave you the answer for secondary hypothyroidism, but we already know that you're going to have a reduction in your TSH levels, and then you're also going to have a reduction in what? T3, T4, and then you're going to have what as a consequence with your hypothalamus? Going to what? Is it going to increase? Yeah, it's going to go up. Now, what about the last one over here? So we're thinking hypothyroidism. What's going on at the level of the hypothalamus? Everything's going to be low, right? Okay, so let's talk about goiter. So I mentioned that with the first column, you're going to see a goiter. Oh, shoot. I gave you all the answers right away. So you are going to see goiter formation with this guy over here because you're going to see that TSH is going to start releasing a lot of like thyroid stimulating globulins that's going to really start to try to activate that thyroid gland. The thyroid gland's not going to do anything, and it's just going to keep on releasing TSH to the point where you start seeing enlargement of the thyroid, resulting in goiter formation. And you're not going to see goiter in these other guys as a result. So. Cool. Let's talk about the parathyroid gland. Are we good on time? It is 4 o'clock. All right, and I only have like 5 questions for quizzes, so we'll do that. Let's do that in like 5 minutes or so. Let's try to blast through parathyroid hormone here. So parathyroid gland is going to be, as the name implies, parathyroid. It's going to be right next to the thyroid gland. And there's going to be 4 different nodules that's associated with the parathyroid gland. And it's also going to be associated with calcium regulation, but it's going to be the opposite of calcitonin. Remember, calcitonin, you're trying to maintain the tone of calcium in your body, right? Your calcium is way too high. Calcitonin starts taking its effect. Now you have stimulation of osteoblasts to build up bone, to take away the calcium from the blood circulation. You have inhibition of osteoclasts, right? Then with PTH, parathyroid hormone, it's going to be doing basically the opposite. If your calcium levels are too low, then parathyroid hormone is going to become activated so that you can start increasing the levels of calcium in your body. It's very similar terminology for the thyroid hormone, for calcitonin. Parafollicular cells, also known as C cells, also known as chief cells. And those are going to be the ones that are responsible for the release of PTH from your parathyroid gland. So if you have low calcium levels, you're going to have activation of your parathyroid gland. Your parathyroid gland is going to release PTH, parathyroid hormone. Pretty easy, right? Same name for the same thing. And then it's going to affect your bones. So it's going to increase the release of calcium from your bones. It's also going to affect your GI tract to help absorb more calcium from your diet. So very similar to what calcitonin does, it's going to affect the osteoclast and osteoblasts, but in the opposite direction, right? So it's going to stimulate osteoclasts. Think about clasts as crushing it down. So it's going to help to try to crush down as much bone as possible to release calcium from reserves into your blood stream. And it's going to inhibit osteoblasts from building up more bone, right? So then the net effect is going to be an increased amount of calcium in your system. It's also going to increase the reabsorption of calcium at the kidneys. And then it's also going to increase absorption of calcium from the GI tract. So you're going to have reabsorption in the kidney, and you're going to have absorption in greater degrees in your GI from your diet. And then you can go through this on your own. I'm not going to beat a dead horse with this, but this is just basically your ability to maintain homeostasis and calcium levels. And it's going to be a balancing act between this guy right here at the top, calcitonin, from your thyroid gland, and then this guy over here, parathyroid hormone from your parathyroid gland. Okay, so it's all going to be in balance to try to maintain that level of calcium. This is going to be within normal limits here, 8.5 to 11 milligrams per deciliter. So that's going to be normal levels of calcium. Nothing really too crazy there. Let's go over adrenal glands a little bit. Some people refer to them as suprarenal glands, but for the sake of this class, I'm not going to refer to them that way. I'm going to refer to them as adrenal glands. One of the main reasons why I personally don't want to refer to them as suprarenal glands is because you find adrenal glands in other animals too. Except, as opposed to us, in other animals, you'll find the adrenal glands sometimes right directly adjacent to like the abdominal aorta, or you'll have it in like different locations in the abdomen. It's not always going to be associated with the kidneys. So suprarenal, I like to think of these as being like a cross species, right? It's not just humans. Some species don't have that feature. But for us, for this class, we're just going to talk about it as being adrenal glands, even though it kind of means the same thing, but it's kind of my own preference, all right? And then in the adrenal glands, you're going to have 2 major layers. There's going to be the adrenal cortex, and there's going to be the adrenal medulla. The adrenal cortex is going to be subdivided into 3 separate layers, whereas the adrenal medulla is basically just doing one thing, and that's production of norepinephrine as well as epinephrine. The adrenal cortex is going to be subdivided into the zona reticularis. That's going to be the most inner portion. Zona fasciculata is going to be the next portion out. And at the very outer portion of the cortex is going to be the zona glomerulosa. Okay? Now, in terms of what's produced by these, so let's talk about the adrenal medulla. That's going to be over here. The main things that are produced by the adrenal medulla, it's all going to be part of that sympathetic activation, right? Fight and flight. It's going to be norepinephrine as well as epinephrine. And then in terms of the components of the adrenal cortex, you're going to have three different groups of hormones that are released at the different levels of the adrenal cortex. Now, the zona reticularis is going to be the innermost portion. That's going to be mostly associated with sex hormones. So let me show you what that looks like here. So DHEA, where's that? So androgens. So that's going to be sex hormones coming from the zona reticularis. That's going to be the most inner portion. If you move up to the zona fasciculata, that's going to be involved in glucocorticoid release. Gluco, think glucose. Corticoid, think cortisol. Remember what cortisol does? It's one of your stress hormones. When stress hormones are released, what they do is they help stimulate the production of glucose. Okay? So think glucocorticoids as being associated with glucose production, and think about cortisol as being the main hormone in that pathway. Then the very outer layer is going to be your mineral corticoids. When you hear the word mineral, you're going to think like electrolytes. Okay, so mineral corticoids are going to be electrolytes. Think aldosterone. What does aldosterone do? Helps to reabsorb sodium, right? So it helps to maintain sodium balance. So when I was in med school, and this is what I'm going to close with before we go into quizzes, the way that my good friend of mine, he had a little mnemonic that he came up with himself to try to remember the different components of the adrenal cortex. He looked at it as being going from young to old. Young in the middle and then old on the outside. And so what do young people mostly concern themselves with? Sex. So the major hormones produced by the zona reticularis at the very middle, besides the medulla, but the next layer out, is going to be sex hormones. When you get a little bit older, what happens? You start getting really stressed out, right? So young people, sex. When you're a little bit older, now you're thinking like stress, life stress. So you're thinking cortisol. Then what happens when you get really old? You're mostly going to be focusing on salt. Right? Salt balance. So old people are going to be mostly thinking about salt. So that's the way you want to maybe conceptualize it. Think sex hormones, think stress hormones, and then old fogies. Salt balance. Okay? So those are going to be the major hormones, the main hormone groups produced by those different levels. So with that being said, any questions before we go into quizzes? Okay, let's go into quizzes. We're going to recap on this, so we'll continue on adrenal cortex on Thursday, and then take it from there. So let me fast forward to the link. There we go. All right, so go ahead and log into quizzes. Let me do a head count. See exactly how many people are going to log in. So I counted 56. I might have counted wrong, but if we get close to 56, then we'll go ahead and begin. And if you are unable to log in for whatever reason, write down your name on a piece of paper and give it to Sawudia before you leave so we can jot down your attendance. All right, 2 more. 1 more. Did I count wrong? Okay, so for the interest of time, yeah, there we go. All right, I'm going to go ahead and start. If you, for whatever reason, weren't part of that, go ahead and just write your name down. All right. So most of you guys got it wrong. The CRH is corticotropin releasing hormone. Okay. So look at the R. Maybe that'll help you like try to say, okay, that's probably coming from the hypothalamus, right? Remember the hypothalamus releasing hormones and inhibiting hormones. Okay. So if you see CRH, if you see TRH, right? You're thinking of a releasing hormone and you're going to try to think that's going to be hypothalamus. So definitely not ACTH. Once the hypothalamus releases CRH or corticotropin releasing hormone, then it's going to go down to the anterior pituitary, aka the adenohypophysis, and it's going to stimulate the release of adrenocorticotropin hormone, right? Adrenocorticotropin, adreno meaning adrenal glands, corticotropin meaning relating to cortisol. So it's going to release mineralocorticoids. Does that make sense to you guys? Yeah? No? Maybe? If you have any questions on that, let me know, and I'll do my best to help you come up with other ways to memorize all that. Good. We got to give you guys an easy one every now and then, right? Okay, we just talked about this. If you make a mistake, don't feel bad. Do the best you can. All right, cool. All right, so the adrenal cortex is going to be subdivided into those three layers, right? That are going to be responsible for sex, stress, salt. At the very like inner layer is going to be the medulla, right? Then outside of the medulla is going to be the zona reticularis, and the zona reticularis is what releases. Did I do this wrong? I totally did it wrong, didn't I? I did. Sorry, hold on a second. Oh yeah, no, I didn't. I did it wrong. Dang it. Sorry about that. So the zona fasciculata is going to be associated with stress hormones. Stress hormones that my body's probably releasing right now because I did this wrong. So that's going to be glucocorticoids. So the majority of you guys got that correct. I apologize. I got to fix that. So, okay. I don't need to explain that, right? Well, let's go through it. The medulla, outside the medulla is going to be the zona reticularis, and then the zona fasciculata, which is this. And then the very end, at the very outside, is going to be the zona glomerulosa. So that's going to be sex, stress, salt. The inside is going to be reticularis, androgens. Fasciculata is going to be glucocorticoids, and then salt, mineralocorticoids. That's embarrassing. Next. I hope I didn't put this one wrong either. In my defense, I wrote these questions like right before I came over here, so I was in a hurry. I think I maybe this one correct here, so let's see. All right, good. So yes, mineral corticoids, think salt, right? Minerals. I don't know. Good way to remember it. All right, last but not least, and then we can get the heck out of here. The answer is D, by the way. Nobody answered D? You guys. Yeah, so primary hypothyroidism, right? So the thyroid gland isn't producing. The pituitary gland is trying to stimulate it. So in that process, it's going to result in goiter formation. Awesome job, guys. I will see you all on Thursday.